Peter Guanich from Leeds University. He's an eminent professor in England and in Europe and all over the world. Professor Peter will speak about complex acetabular fractures. Unfortunately, Professor Peter just called me. He will not be able to be in this session with us because he has another talk with Japanese university in the same time. So he recorded his talk and we will watch it. Mr. Khaled?
It is my great pleasure to participate to this exciting educational event. I am Peter Giannodis. I work in Leeds, England, and the topic I was asked to share with you today is challenging acetabulum case. So this case refers to a 24-year-old male who was involved in a road traffic accident, motorcycle versus car. He was the motorcycle driver. During the course of the accident, he sustained lung contusion, a left wrist fracture, and a fracture to the left fifth metatarsal. When he presented to our department, there was no neurovascular deficit present. He underwent the trauma CT scan, and you can see here his trauma CT that demonstrated where is the white arrow fracture to his femoral head and also a fracture to his acetabulum, which on the sagittal cuts appears to be a fracture of the posterior column. These are the coronal views of the CT, and you can see where is the red arrow, that there is an element of central impaction injury of the acetabulum in addition to the fracture to the femoral head. So we've got now this unique injury with a central impaction of the acetabulum, a fracture to the posterior column, but as you can see, there is no fracture to the posterior wall. And the question is how we should manage this case, what should be the approach, what should be the technique of reconstruction. So the patient was taken to theater, a posterior approach was utilized. You can see here the Koch-Langenbeck incision, and then the exposure of the acetabulum posteriorly. You can see here the posterior wall, and here you can see the detachment of the obturator internus gemelli and the piriformis. And then if we come closely to the area of interest, what you can see here, this is the posterior wall. You can see here a small articular fragment which is at the border of the posterior wall of the acetabulum. And this fragment was from the femoral head. And since we could not get any access, you can see back here the fracture to the posterior column. It was decided to proceed with the osteotomy. You can see here my marking of the osteotomy and the K-wire at the center of the posterior wall fragment, so that I will osteotomize the posterior wall exactly where I want to get access to the injury inside the socket. So multiple drill holes, as you can see here. And then you can see here the osteotomized posterior wall fragment elevated. This is the cartilage of the posterior wall. You can see here the femoral head fragment, and this is the lesion on the femoral head. And right here, the central impaction injury of the socket of the acetabulum. So in the first instance, the fragment from the femoral head was reduced, as you can see here, and it was stabilized with two 2mm screws. And you can see here the overall fixation and reduction of the Pipkin fracture. And then, obviously, we need to deal now with the central impaction of the acetabulum. It was mobilized, reduced, and it was held with a K-wire. But as you can appreciate, when you mobilize the impacted injury, then over it, just above the subchondral area, you ended up having a void because of the initial compression of the cancellous element of the impaction injury during the accident. So that area of impaction, as you can see here, it was filled for stability with a block of cancellous bone. This is bovine. And then where was the K-wire and the central impaction was reduced, and you can see how you can use the femoral head for as a template. A 2 millimeter screw was applied for stability just next to the wire in the subchondral area outside of the joint. And this technique, we have previously described it as a 2-level reconstruction technique of comminuted posterior wall acetabulum fractures. So basically, this is your impaction fragment. This is the cartilage. You rotate that to the femoral head, and then just underneath the subchondral area, you can insert your 2 millimeter screws. And this technique is very good to allow you to reconstruct the most difficult impaction injuries of the joint. And here you can appreciate the postoperative pictures. This plate stabilizes the posterior column injury. This is the osteotomized posterior wall. These 2 lag screws from the wall, from the posterior wall to the posterior column for stability, and the plate neutralizes the wall fixation, and the 2 millimeter screws that they were used to stabilize the femoral head fracture. So to conclude, I demonstrated to you how you can approach this challenging case. Of course, every case requires attention to delineate the exact injury pattern so that you can plan your preoperative solution in such a way to make sense and to allow you to get access to the joint. And if you are not familiar how to deal with an injury, then obviously the best thing to do is to phone a friend who has possibly more experience or has done a case like that to assist you in your preoperative planning. And with that in mind, I would like to thank you for your attention, for listening, and I wish you a successful Congress. Thank you very much.
Thank you so much. Now we will move to the second speaker, Professor Hemant Sharma from Hull University and the eminent star in reconstructive surgery and deformity planning in UK and all over the world. Thank you so much, Professor Sharma, for being with us tonight. Thank you so much, sir.
Yeah, can you hear me and see my
Yes,
screen?
sir. Yes, sir. We can hear you, sir.
Hi, Hemant. Hello. Hello, everybody. And I can see a lot of familiar faces. So thank you so much for the invitation. And I always enjoy. And I was just thinking that had it been not pandemic, I would be in the warmth of Cairo, but some other time. My name is Hemant Sharma. I work in Hull, which is actually not far from Leeds. It's the same road which connects to both of us. And my principal work is limb reconstruction, and I'm going to just to give you a brief overview of the gradual deformity correction following the growth plate injuries. So I want to thank my colleague Liz Mulder for giving me some slides. What we're going to hope to talk in this talk is that we will run a few indications, some potential problems, and the basic factors to consider, and some of things you would have heard, and I'm not telling you anything new, so just a bit of a revision at times. Now, what happens is that whenever there's a deformity, we do X-rays in 2 views, but actually it's a 3-dimensional deformity. And so when we look at the deformity, we need to look at the 3-dimensional and that is the best way to analyze and then help us correct the deformity. One of the problems is that when the child is very young, then magnitude of deformity can be quite significant. It could be complex, and often child can have multiple surgeries. And the problem is, if we leave it for too long, then one of the problems can happen is that secondary compensation. So some other joints will start compensating at the epiphysis, as you must have seen in the proximal varus deformities. Distal tibia will start going into valgus, and sometimes the joint can become a bit stiff and grow differentially, so that needs to be kept in mind. What we need to look at before we correct the deformity. So we need to look at the entire deformity in terms of the complexity, how it works, and the magnitude, everything is compensation, and along with the leg length discrepancy and the predicted leg length discrepancy. Along with, we need to look at the patient factors, look at the family, the problem, what age is the child, and what actually, what is best for the child in the family circumstances. So I would always suggest to make a problem list. So there's some obvious problems from the bone, from the joint, subluxation, compensation, all that. We know about that. We look at the potential problems. Then when we correct the deformity, what can happen, and we try to compensate or plan for those and see if we can avoid them. Then lastly, we need to look at the family problem, how far they live, traveling to hospital, financial, social problem, aspects of it before we start any deformity, any correction. The other question we need to ask ourselves is, how will we maintain the correction, and what is the leg length discrepancy at maturity, and how we're going to tackle that? Now, generally, it is accepted that the gradual deformity correction gives you more accurate correction. That is because we tend to correct slowly, and we do it quite, especially with the frame. All large deformities and all the deformities where the acute correction can be difficult are the right indication for the gradual correction. Even the smaller ones are good because the accuracy is better. Then at the situation we can't do the acute corrections, where there's a neurovascular problem, previously it hasn't worked, soft tissue problems, or especially when we have leg length discrepancies, then we need a bit of length. Then acute gradual is better because we can lengthen the leg. The disadvantage of the acute correction is it's very difficult. If you can't get it right on the table, it's very difficult to do it fine-tune post-operatively. Accuracy can be a problem. You need to plan it very well. And if it is complex, then it can be a bit difficult, and neurovascular structures can be a problem. How we can do it? The most common method is the 8-plate or the staples, which used to be in the past, axial fixation, and sometimes we do with a combined method. Now, when we do gradual growth plate, gradual correction is with 8-plate, is when there's enough growth remaining. That is the principal issue. We can correct practically all planes. Some are more easier than others, and sometimes an oblique plane can also be a possibility, as long as we can put the growth plate at the 8-plate at the apex of the deformity. We can also correct in some abnormal bones, though it doesn't work as well then. The biggest advantage is the process can be repeated. So this child had a problem after the removal of the plate. All you need to do is put another 8-plate, and it corrects slowly and comes straight. External fixation, if it's a leg length discrepancy, then perhaps that is the best thing. Quite good for large deformities and where there's a growth plate injury, where there's bony block is not amenable for excision, and there you can do that. This is an example of a child where you correct the deformity. Once the deformity is corrected, you need to decide how you maintain it. Do you fuse the contralateral epiphysis along with the same side? Or do you leave it and lengthen the child later on, or maybe at the age of around the maturity? These are the clinical pictures. Then sometimes when the deformity is bad, it's not too bad to put in 8-plate and if you can improve the deformity a little bit and correct it, although it is very hard to correct these because the forces are too much and they often break, and therefore, but the combined method can sometimes be used. And this is the correction from the neglected blounce from bilateral to this. And then we need to keep an eye on them because the biggest problem is they can recur, and then you have to ensure that they don't recur. And when they recur, you catch them early so that deformity don't become too bad. And this is the important factor we need to consider. How do we maintain it? So one, regular follow-up. And as soon as you get a problem, you can put 8 plates and then repeat the problem, the correction. Sometimes you just only remove 1 screw, and therefore all you need to do is put in a 2nd screw if the problem recurs. Other problem is the leg length discrepancy, which you can correct at the maturity when the child grows, or if it's too long, then you have to more than 1, or the epiphysiodesis on the same side and contralateral side is also a problem. Always keep a pragmatic approach, i.e. that you don't have to correct every deformity. Sometimes you overcorrect one to compensate further, which will be easier for the patient. The problem with all these things is the number of hospital visits. Patient compliance can be a problem. The advantages are is percutaneous, can be repeated, it is very accurate, and the soft tissue and the neurovascular structures are not a problem. So to summarize, it's a fantastic way, especially with 8 plate. The only thing is we need to plan it, analyze, and make sure that we do the right thing for the patient, and we plan it and we plan ahead. Set realistic goals, and talk to patients, and then always do it provides more accurate correction. Thank you very much.
Thank you so much, Professor Sharma. Thank you so much.
Can I ask Dr. Mohammed a question?
Yes, please. Please, sir.
Yes, sir. It's a very nice and comprehensive lecture, but I want to ask if there is any role for internal fixation correction for these deformities.
Yes, there is, and my topic was on the gradual correction, therefore I put that, but I do a lot of acute corrections as well, and especially when the growth plate is fused or about to be fused and leg length is not a problem, then you can equalize the leg length, do the acute corrections, and do the epiphysiodesis at the same time, so the chances of leg length discrepancy is not there. So yes, there is a role, sir.
And also we can combine both together, internal with external correction.
Yes, you can do that as well. The only thing I would suggest is that we need to make sure that internal and external don't touch each other. The only reason for that is that there has been reported increased risk of infection if that happens. And therefore, if we plan both, then we need to plan it in a way that your wires and half pins do not touch the internal fixation device.
Yes, thank you for a very, very nice lecture and
thank you.
Professor Sharma, I think at the end of this session, we will have lots of questions for you, sir. Thank you, sir. Now we will move to the...
May I introduce Professor Gamal?
Of course, sir. Of course, sir.
Yes. Now Professor Gamal will give us a talk, which is with a strange address. That's if the patient asks for amputation, what to do? For Gamal.
Okay, thanks, Professor Ala. I would like to welcome my friend, Professor Hemant Sharma. It's a great privilege to have you in this session. I want to remind everybody of our next scientific activities of the Egyptian Orthopedic Association. The next clinical meeting will be on Thursday. I would like all of you to attend. We have our 17th International Cairo Deformity Conference, 4 to 7 August. And it's expected to be face-to-face. And Hemant, of course, you are invited. I hope everything is okay with the COVID-19 during that time. We hope
I'm coming.
Yes, we are waiting. We have also our International Pediatric Orthopedic meeting with MIPOS or the Middle East. Association for Pediatric Orthopedics, 14 to 17 October 2021. We're expecting everybody to come. Now coming to a simple case. It's very simple. Why? It's a case of resistant run union, and the patient is asking for amputation. There is nothing easier than this. The patient has solved the problem. He's asking for the amputation. I'm going to tell you the story of this patient. 6 years ago, or more, 6 years and a few months, the patient had an open fracture, and he was 14 years old. And we don't have the first X-ray, but the patient had been treated by debridement and this internal fixation. The patient stayed in the hospital for 3.5 months, and he had severe infection and had been treated by rotational flap, and he had 19 times debridement, and he had rotational flap and many skin grafts. He does not remember the number of the skin grafts were done. And he gave us this picture after 9 months with non-union and a gap and osteomyelitis. This was December in 2015. Then for a couple of years, 17 and 18, he was treated by a surgeon as repeated casting, antibiotics, and a few debridements for a couple of years. And you see the picture during this for a couple of years. Then he had debridement, unilateral fixator, and cross-leg flap. So this was the unilateral fixator. He was treated in many hospitals and many facilities, so we don't have the original data. All these data are given by the patient and the X-rays he had, because he didn't have all the X-rays. Partly because the hospital didn't give him the X-rays, and partly because he burned the X-rays because he does not want to see the history. For him, it's a painful history. So finally, in 2019, at the early 2019, the patient had a circular fixator and bone transport. Corticotomy was done and bone transport. The patient was referred to me after 10 months in the fixator. And this was the picture. Look to the skin and the deformity. It's almost like a Z-shaped deformity of the tibia. Have a huge bone defect. He has poor regenerate, many plastic operations. Look to the normal side. And look to the normal femur. And you see the regenerate, the bone defect, severe osteoporosis, and a frame with severe pen tract infection. And now it's 10 months. And he was referred to me at that stage. And look to the picture again. We have this defect. It's about 15 centimeters. Poor regenerate, bone defect, united fibula, almost S-shaped deformity.
طب كويس، بعتهولك على البيت.
What's left? We have all the osteoblastic procedures: rotational flap, cross-leg flap, multiple skin grafts. The bony procedures, you have intramedullary fixation, multiple debridement, casting, unilateral fixator, circular fixator, and bone transport before. Psychiatric problems. It's easy. The patient is asking for amputation. But he's only 18 years old. And you know, in Egypt, it's not, he has to reach 21 to decide for himself. But it was wise. because look to the skin, it's almost adherent skin all over the tibia. You see, laterally, medially, anteriorly. Look to the knee, the incisions, adherent scars. Look to the healthy leg. Again, we had many scars in the healthy leg. Look to the femur on both sides. You know, both sides are not normal. So what's left? Do we have other options? After, in the clinic, we removed the fixator immediately. Why we removed the fixator immediately? Because it was severe pentrache infection. And we thought it's going to give you osteomyelitis or ring sequestra at the site of the injury. So what's left? Can I ask you about the options, apart from the option of the patient that he needs amputation? Professor Sharma, do you have options?
Apart from transporting the fibula across, there's very little you can do. I mean, you can do a bit of proximal lengthening. The only thing I can say, I'm very lucky I don't see these cases. They all go to you. So thank you so much for that.
Professor Ala, do you want to add something, or Professor Osama? Your voice, Ala.
Professor Gamal, I believe.
I think it is very difficult, Dr. Gamal. Dr. Khalid.
ازيك دكتور علاء بيه؟
اهلا وسهلا.
صح يا باشا.
طيب I think اتفضل يا دكتور خالد.
لا مؤاخذة بيه، العفو، اتفضل.
لا اتفضل.
دكتور جمال، ازي حضرتك يا فندم؟ I believe tibialization of the fibula is the best solution for him before amputation.
I agree with you, but the problem with the fibula is deformed. This is the real problem. It's deformed with a deformity of the soft tissue around it, and it was difficult.
Yeah.
So do we have other questions?
Is there any infection now, Dr. Gamal?
No.
No infection.
When we removed the fixator, after a couple of weeks, there was no infection.
Yes.
Dr. Gamal, vascularized fibular graft from the other side?
The problem with the other side that when we thought about the free vascularized grafts, the plastic surgeon said that I'm not sure of the bed because of many previous operations in the leg and cross-leg flap, and he was sure that most of the vessels are not patent to have a good recipient for the free vascularized fibula. So he thought, my plastic surgeon thought it's a straightforward case for amputation. So we discussed the amputation with him, but the problem was he cannot do below knee amputation because look to the skin, even around. So he suggested above knee amputation. And the patient is 18 years old, and the family refused this option because, you know, we have to take the consent of the family before the age 21 in Egypt. This is the law, so we cannot. So even if we thought about amputation is not a good solution because above knee amputation is something, and below knee amputation is something else. So although this was the picture again to remind you what we did. We put the frame and we did close the corticotomy. You know, this is very osteoporotic bone. So there was no way to make any incision in the proximal part. So we put the frame, and we removed part of the fibula because it was very deformed to allow for correction of the deformity, acute correction of the deformity of the leg. Then we did osteoclasis. We put the frame here and there. Then we did angulation and translation. So we did close the corticotomy, proximal part. And we did open corticotomy of the distal part, this here. And we fixed the heel to correct the equinus deformity. So this was osteoclasis. This is the best corticotomy. It's not open. We kept all the blood supply. And We removed this part of the fibula and open corticotomy through bifocal corticotomy. Then we did gradual compression. Gradual compression, bifocal distraction, one from the closed corticotomy and one from the. We continued the compression and the distraction. And you see here the gap. The regenerate is okay, it's fine here, it's about 10 centimeters. And the regenerate here, there was a problem with the open corticotomy. We did compression distraction many times in the distal part, perhaps 5 cycles of compression distraction. But there was no problem at all with the regenerate of the closed corticotomy. But it ended up with this. It was okay. The problem was during the COVID-19 area and the lockdown, and we thought we had soft tissue interposition here. So again, we asked the patient to go to the plastic surgeon we usually ask the plastic surgeon to do an incision here and to remove this soft tissue interposition in between, and we do compression. For one reason or another, he refused to go there. The patient has depression, so he refused to go. And he asked 100 times to remove the fixator and to do an amputation. He went to a psychiatrist, but I don't think that he improved. So we left the patient for some time, partly because he refused to go to the plastic surgeon, and partly because of the COVID-19 situation. So we didn't see him very often. Anyhow, he had good regenerates, and this was the picture just before removal. We continued the distraction, the compression. We continued. There was no other option. So we just did more compression and more compression and more compression. Look here. You see the distance and this distance. We don't have another option, just compression and just compression. And we left the patient in a frame, and for a few months, he refused to do any dressing or to put any disinfectant because he wants to get rid of this frame. Finally, we responded to him and we removed the frame and looked to the picture. Complete union. Complete consolidation. We thought with the severe compression, we just pushed the soft tissue away from the bone. We didn't intend to, we didn't. This was the plan. So this was the picture. Look before and after. Look to the regenerate. Looked out to the complete union. Do you think we have a problem? Everybody's happy, his family is happy, but still the patient is asking for amputation. Can you imagine? Because we didn't solve the psychiatric problem till now.
How long, Dr. Gamal, this will take?
He stayed in the frame for 1 year, 1 complete year. But now it's about 7 years from the date of injury. Maybe about something like 30-something procedures. He was admitted to the operating theaters more than 30 times.
Why you don't think for amputation and we put a plastic appliance or something like that, even above knee?
Above knee amputation is not a good operation. It's not a good operation at all. Functionally, many of the patients that's why the osseointegration had been invented. Osseointegration by putting an intramedullary load and another frame, because below knee amputation is something and above knee amputation is something else. And he's only 18 years old and the family refused the amputation solution completely. You know, the families here, they don't think amputation is the reconstructive procedure.
But I think the general condition of the patient would be affected by these very long operations with anesthesia, infection, and something like that will affect the liver. If it can.
He didn't, you know, he didn't do any dressing, I think, the whole 1 year. He just left the frame as it is for the whole 1 year, but we don't have osteomyelitis or something. He's okay now, he's walking, he's fine, but the psychiatric problem had not been solved.
And the skin condition, muscle, something, what's the result?
Okay, okay, it's the same skin condition. There is no problem at all. So do we have other remarks?
Thank you so much, Professor Gamal, for this marvelous case. Thank you so much, sir. Fantastic as usual, Dr. Gamal.
أسامة فاروق معانا.
مع حضرتك. Congratulations, Professor Gamal. Congratulations for solving the problem of this young patient. Actually, above knee amputation is not accepted in a young age, 18 years old, in such a situation. And I think you did your best to achieve union of this difficult case with a gap, non-union with a gap, after several failed surgeries before. So it is an amazing case. Thank you very much for presenting it.
Professor
Khalid. Khalid.
ازي حضرتك يا فندم؟
Can you introduce the next speaker, please?
I believe I don't have the list right now in my hands. I'm sorry.
Oh, okay. Father Osama.
Okay. Now it is my great pleasure to call Mr. Dry Nayagam from United Kingdom. He is going to talk about limb reconstruction case. Please, sir.
Welcome.
Professor Osama, I am sorry. Dr. Duray Nayagam is recording his talk. He will not be able to be present live with us. So he's recording his talk and it will be immediately shown.
Okay, thank you.
Good afternoon to all, and my thanks to Professor Hosni and Professor El-Hassab for the invitation to join you on this webinar. The case I would like to present is one of radial aplasia. This is a case that highlights the power and the strength of distraction according to the laws by Elizarov using the principles of tension stress. And here we will combine the technique of gradual wrist centralization with augmentation using internal fixation. This is a 18-month-old boy with a unilateral radial club hand or radial aplasia. As you can see from the clinical photographs, there is an absent thumb. The entire upper limb is shortened, and if you were to examine the child, there will be, in addition to absent wrist movement or very little wrist movement, there will be some restriction of elbow flexion, as these children often have flexion to only 90 degrees. You need to always be aware that this condition is associated with syndromes like VACTERL, TAR, Holt-Oram, which indicate some potential spinal, renal, cardiac associations. As you can see from the X-ray, the forearm and the arm itself is shortened, and in this particular case, there are only 4 digits. The overall plan for treatment is to start early, and the rationale for starting early is to enable the wrist to be centralized and to provide a stable platform for a pediatric hand surgeon to policize one of the fingers and thereby create a thumb. In so doing, you have the potential to allow the child to learn to grip and grasp normally. It is common to find the radial fingers on this arm stiff, and therefore to really anticipate normal hand function is a little too ambitious. But however, these children can be able to learn to grasp and to grip well. The follow-up of these children has to be done until maturity. In my practice, forearm lengthening is seldom required because compensation for differences in arm length are made much more easily than that in the lower limb. So, the technique involves using an all-wire Elizarov, and as these children are often under the age of 18 months, the forearm is generally much smaller than the normal forearm, you may find having to use much thinner wires than the usual 1.5. In fact, in my practice, we tend to use 1.2 millimeter wires. We always extend the fixator across the elbow, although it's more common to find problems with elbow subluxation during correction with ulnar aplasia. It is also possible with radial aplasia, and this would be a complication best avoided. Always inform the family that the process of moving the hand from the side of the forearm over to the end of the ulna may take up to 3 months, and therefore to be patient for the correction to be achieved. So the plan of the surgical technique essentially involves 3 rings. 1 in the distal humerus, 1 in the proximal ulna, and 1 across the metacarpals. Usually 2 wires are used per ring. There is very little space in that very small forearm, so you need to be aware that sometimes you have to build the rings away from each other using posts rather than connect the wires directly onto the ring itself. The position of the hinges is relatively straightforward. The trick is to rotate the forearm under the C-arm until you get the deformity in maximum view. And in this particular X-ray, you can see that we have just that projection with 2 threaded rods showing the line of the ulna and the line of the metacarpals. So the intersection is essentially the core of the deformity. And by using these 2 lines, you can then determine where the transverse bisector line is and thereby place your hinges accordingly. And this should be done in the plane in which the deformity is seen maximally. So this is often an oblique plane and not an AP or a lateral or a coronal or sagittal position. So here you are, we have the hinges placed on the convex side of the deformity on the transverse bisector line, and this is usually enough to achieve not only distraction but correction and due translation of the deformity. So here again in the diagram showing that this is on the transverse bisector line and on the convex side. This is the beginning before the start of correction, and this is during the progress of correction, and you can see on the right hand slide we have moved that wrist considerably further over the end of the ulna. And this is just before we moved to the second stage of treatment, which is usually about 3 months after the start of correction. In the second stage of treatment, the entire fixator is removed, and from that point, through small incisions over the wrist and over the end of the third metacarpal, a track is created in order to pass a K-wire. Usually with an 18-year-old, the maximum size of K-wire you end up using is 2 millimeters. Often, the ulna is bowed and an osteotomy of the ulna will also be required. We often reapply a new Elizarov fixator, usually consisting of only 2 rings, to act as a plaster cast over the centralization. As you can see here, the centralization is the ulna over the third metacarpal. In this particular example, a thumb has already been created by the pediatric hand surgeon, so these x-rays represent a treatment further along the line. The end result cosmetically is very gratifying. Here is a before treatment and after treatment photograph of the same patient. It's worth noting that when you use the K-wire, and as the child grows, it often requires revision, either because the K-wire becomes too short, or after a certain length of time as the child becomes larger, the K-wire may fracture. That gradual increase in canal diameter allows you to use bigger and bigger K-wires as the child grows older. When the metacarpal diameter gets to beyond 4 millimeters, it is possible to insert a telescopic rod, and these tend to last much longer and sometimes as long as 3 to 5 years before revision is required. Our practice, and we've been using this technique for over 20 years, is that the wrist does not require formal fusion. Usually these wrists will autofuse by around the age of 12. So here are some clinical examples showing a case where a K-wire was used initially on the images on the left, and then as you progress to the images on the right-hand side when the child is aged 8, we have substituted a telescopic rod because the canal diameter of the metacarpal allows us to insert the smallest telescopic rod, which in our practice has an external diameter of 4 millimeters. And here the final picture showing in a different case how the wrist has autofused completely without any formal need of fusion by the age of 13. And this is something we find that occurs quite commonly. There are alternatives. There are open procedures that described by Gramco and by Paley, but we have chosen to use this technique and this plan simply because there is no real wrist joint. Even though these other techniques create some modicum of movement, there is no true wrist joint because there is no synovial joint form, as there was no radius in the first place. We feel that stability is more important than actual movement, however small, and that hand function with a new thumb is really limited to only grip and grasp, because many of these children do not achieve fine pinch ability. So to conclude, the tips I would like to share with you from this particular case of radial aplasia and from our experience is to offer centralization early. If it is a bilateral case, to offer it only to one side, because the corrected side may have difficulty in reaching the mouth, even though it's very good for grip and grasp, but the untreated side will be able to allow the hand to reach the mouth. Gradual transposition is by the Elizarov method, and this is to facilitate a stable wrist so that polysization can be carried out. There's no need for formal fusion as the child gets older, because most of these wrists, as long as you maintain the internal fixation, will autofuse before skeletal maturity. I thank you for your time and thank you for the opportunity to participate in this program.
Thank you. Now we go to the last presentation in this session. That's our dear colleague from Tunisia, Dr. Sufyan. He is an AO member with us in different courses and meetings. He will speak about open book fractures pelvis treatment. Dr. Sufyan.
Your voice.
Dr. Sufyan, you are muted.
You're muted.
Dr. Sufyan.
Okay, how are you?
Sufyan. How are you, Dr. Sufyan? How are you?
How are you?
ازيك؟
الحمد لله، كيف حالك دكتور علاء؟
وحشنا والله. ازيك؟ اهلا. عاوزين نشوفك بقى في القاهرة ان شاء الله. عاوزين نشوفك في القاهرة بقى ان شاء الله.
ان شاء الله. انا I was very happy when I see by Dr. Gamal the announcement of the meeting of next August. ان شاء الله. ان شاء الله. ان شاء الله. ان شاء الله ربي يحفظنا وإياكم.
تونس اخبارها ايه؟ تونس عامله ايه في الكويت؟
الحمد لله.
دكتور سفيان، ازاي صحة حضرتك دلوقتي؟
الحمد لله الحمد لله.
احسن من امبارح الحمد لله.
احسن الحمد لله.
الحمد لله. الف لا بأس عليك يا فندم.
احنا سعداء يعني ان one of our AO eminent members will be with us in this session.
يا سيدي مرحبا بكم، يعيشك. All the pleasure is for me. والله عاد انا مدخول ممنون جدا يعني ان نكون بيناتكم.
اهلا دكتور سفيان، اتفضل.
احسن.
معانا الدكتور أسامة فاروق
اهلا بيك دكتور سفيان بيه، اهلا بيك، اهلا بحضرتك، اهلا بحضرتك.
الحمد لله. أنا في بالي my presentation was uploaded, but I think.
Yes, sir. It's uploaded, sir. Mr. Khalid, can you upload can you make the presentation of Dr. Sufyan obvious? Mr. Khalid?
About the difficult acetabular case till Mr. Khalid upload the presentation of Professor Sufyan.
Yes, sir.
This is a very difficult situation when you have articular impactions that you cannot access through your surgical approach. And he presented an elegant solution to do osteotomy of the posterior wall, which is kept for the expert surgeons like Professor Gianoudis and his dedicated pelvic acetabular team. We may have other solutions such as the Gibson approach with trochanteric flip osteotomy to access the interior of the acetabulum and to elevate the depressed articular fragment, the articular impaction. For the surgeons who are familiar with surgical hip dislocation, we have another solution for those who are not familiar with surgical hip dislocation to create an iliac window, but you should precisely plan for the site of the impaction from the CT scan and intraoperatively from the CR, so you can put a guide wire directed to the site of impaction, open a window in the iliac bone using, for example, the drill bit of the triple reamer, so you can have a good channel to work. Then you put bone impactor through this working channel and disimpact the articular surface from the iliac side till it is congruent. Then you put iliac graft like we do in the tibial plateau fracture and drafting screws to keep the position and then proceed with your internal fixation. If you have a posterior roll fracture or a rent in the posterior roll, this may help you to put a femoral distractor and distract the joint to see the interior of the joint and guide the reduction of the articular surface. So we have 3 tricks to reduce the articular impactions in acetabular fractures, in addition to the technique shown by our great Professor Peter Gianoudis.
Thank you so much, my dear Professor Osama Farouk, for this very valuable comment. Thank you so much, sir.
You're welcome. It's my pleasure.
دكتور سفيان جاهز دلوقتي ولا ايه؟ دكتور سفيان.
Yes, no.
Mr. Khalid, you are ready? Mr. Khalid?
Capture l'écran, utiliser.
You can move لغايه ما المشكله تتحل عشان التوقيت. دكتور محمد لاشا.
Okay. We can go to the second presentation of Let's Company. Mr. Khalid?
Okay.
تمام حاضر يا دكتور شغال حاجه.
Yes, please.
شغل لابتس شغل.
Previous one.
The previous one, Mr. Khalid.
Yes, I said that the challenges in the importance of displacement and how to reduce this fracture. When to reduce them is as soon as possible. Which approach, the most convenient approach is the stopper approach, anterior stopper approach for the symphysis. How to fix anterior and posterior or anterior only, plate fixation, locked or non-locked plate. Next, please. The key in treatment of this type of fracture is the setup. Setup is the key of success of this type of osteosynthesis. You need first of all to put a Foley in the bladder or a catheter. Some patients comes to already to the hospital with their catheter, which has been done in other hospitals. And the problem with the catheter that it creates some adhesion between the rectus abdominis and the peritoneum, and we should be aware about that and the difficulty of how to separate this space and to treat this adhesion. The position of the C-arm is very important. We have to control the inlet and the outlet view of the pelvis. It's very, very important. You need translucent table and you need to put the cushion, which is under the patient, to level higher the level of the patient and to see the sacroiliac joint on the lateral view. The surgeon should be always on the right side of the patient. Next, please. Then when, as I said, as soon as possible, but previously you have to prepare a good X-ray to evaluate the displacement of this fracture, of the opening of the symphysis. You see the rotation with the index between the two ischiatic points and the lower part of the acetabulum, the distance between the two parts of the diaphysis, and the vertical displacement of the fracture. You have to appreciate all the 3 points: the rotation, the displacement, and the shearing forces on the fracture. Next, please. As soon as possible. Why? We have to treat this patient as soon as possible. Timing. As soon as the patient is hemodynamically stable. You see that these patients have bleeding in the pelvis, and the problem is the hemodynamic problems that occur in the beginning, in the starting of happening of this fracture. The second problem is their complication, because sometimes there is a delay of treatment of this patient, and there is a high rate of complication of DVT and EP. Very high risk of hemodynamic complication in the early phase than DVT and EP later on. Please, next please. Why they have hemodynamic problems? Because after an open book pelvic ring disruption, the mean volume of the pelvic cavity after complete visceral externalization is almost 870 centimeter cube, extremes between 580 and 75. This average of increase of pelvic is 20%. There is 20% more volume in the pelvis when you have a diastasis more than 5 centimeters. In all these cases, because of the transversal dispersion of the iliolumbar pedicle with regard to the sacroiliac joint, reproduction of the open book fracture caused by venous delaceration. There is venous delaceration when the displacement is over 5 centimeters, and the iliolumbar vein is is 5 times risk of delaceration, and the pubic diastasis, when it is more than 5 centimeters, is 60% of delaceration of the veins. There is no arterial delaceration was observed in the iliolumbar artery, but the artery was put in tension. Next, please. The thromboembolic in pelvic fracture are very frequent. The pelvic fracture in the AP compression. There is a rate of 18% in lateral compression, 12%, and in the vertical shearing fracture, they have 35% of risk of DVT. The risk of EP is higher when you have acetabular fracture, which are associated, and it may reach 22%. Next, please. Benha in 2019 showed that even mechanical and chemical thromboprophylaxis, the rate of DVT in patients with pelvic and acetabular fracture is still very high. Most of the thromboses are located proximal to the popliteal vein. They are mostly in the femoral vein. The rate of DVT is higher in acetabular fracture compared to the pelvic fracture. The age older than 60 is associated with injury at the time from injury of operation, more 2 weeks wear and dependent risk factor. The risk of PE varies in the literature between 1 to 21%. Next, please. The approach, as I said, the approach is the STOPA approach. The STOPA approach, I don't know if I cannot share the screen, but I wanted to show you that in this is the bladder. What you see in the upper photo, there is, you see the bladder, there is the symphysis, and the distance between the two parts of the bone. You see the two parts of the bones, and here there is the pin, and on the pin on the right side there is the femoral vessels, and we use this pin to expose the facet, the anterior facet of the acetabulum and the anterior column. In the photo, which is in the lower part, we see the beginning of the reduction of the symphysis. I do not consider this type of reduction using screws in the either part of the symphysis, because sometimes you have osteoporotic bone mainly in more than 60. And if you use this technique, the screws may move and fragilize this part of the symphysis, and you have difficulty to do your osteosynthesis. Next. Unfortunately, there is no video here. Then the first step, the approach. Usually, when you do the surgery, you are far away from the accident, as I said, to stabilize the patient with the risk with DVT and EP. And you go to the you have the video. Very good, very good. This is we are trying to remove all the fibrous part which is in each part of the symphysis, and this is very good. And we are trying to expose the different part above the bone to graft it. Use this part of bone to graft it later on. Next. Next slide. Yes, we see here, this is the very good technique of reduction. You use the retractor in the inside. In the upper part, you see the bladder, which is covered by the champ. And this is the meta reducer. This is the best instrument to reduce the symphysis. You see the reduction here of the symphysis. And this reduction should be progressive. As I said, in most of the time, you do your surgery late, and you have difficulty to reduce it, but you try it in several times. Be patient till you have the reduction with the meta reductor clamp, and you succeed to have the reduction. Next slide, please. Yes, you see here on the video, which is on the left side, the osteotomy of the iliopectineal eminences. Yes, we try to flatten this superior surface of the symphysis to adjust the plate, to have plate which is on the flat surface. Now you have no bump of the symphysis, and then you have the surface which is flat, as you see on the right side. You see the bladder on the left, and here's you see the plate, and you use at least 2 screws from each side of the symphysis. Next. You see here the reduction, and you see with the C-arm, the AP view, inlet view, and the outlet view, the positioning of the screws with the reduction of the symphysis. Next. Then locked versus standard unlocked plating of the pelvic symphysis, a cadaver biomechanical study. There is no difference between locked and unlocked. There is no advantage on the symphysis to use locked screw, LCP screws. You can use only DCP screws, and there is no difference in the literature at the moment of the superiority of the locked plate. Next. The impact of early operative pelvic fixation, long-term self-reported, prolonged time to operative pelvic fixation led to worse long-term functional outcomes in patients with severe pelvic ring disruption. Early fixation of the pelvic ring is the only potentially modifiable risk factor for decreased functional outcome in patients with severe pelvic fracture. More early you do your surgery, better the result is. Next. Then at the end, you can see the video, please, on the right. Just on the video. At the end, you will just control what you have done. This is the rectus abdominis, and this is the plate. And just in the upper part, when there is the retractor, the upper retractor is in the face of the corona mortis vessel that had been ligated. Next. No, next slide. Then once you finished the anterior approach, you can go for the posterior fixation. Next. As I said, the setup is very, very, very important in the posterior fixation of the pelvis. Next, there are different techniques. The most classic one is what you use 2 key wires, AP and lateral view, and the vertical key wire you see here is the axis of the femur almost, and the second one, it goes through the first sacral vertebra. Next. Then you put your key wire, and then you fix with the screw. Next. You see the screw here, the reduction of the posterior part And this is, you see the screw that exactly in the intersection between the two K wires that you have seen in the previous slides. Next. Then if sometimes the patients are very, very obese and you cannot see anything on the C-arm on the lateral view, it becomes very difficult. Otherwise, you can do it posterior fixation separate from this anterior approach, and you do your fixation, posterior fixation under CT scan. Here you see I'm doing posterior fixation of the pelvis in the CT scan room, and you have all the facilities in the CT scan room to do surgery under CT scan, and you fix under CT scan. It's very easy under CT scan, much more easier. You got less radiation than in with CR. Next. There is a system which has developed by my friend, Dr. Mohammed Ben Saleh, using the system navigation, which was developed in Charles Hospital here in Tunis. He developed a navigated system used on next slide. The positioning of the key wire, the positioning of the proximal key wire were 5 centimeters almost up to the anterior superior iliac crest. Then you put your key wire, and you have 3D printed system that we prepare before surgery, and you give you exactly, you see on the photo which is on the right, the key wire, which is exactly in the right place, because everything is navigated under on the computer, and you see you will have your wire exactly to the fixation of between the iliac wing and the first sacral vertebra. Next. Does posterior fixation of partially unstable open book pelvic ring fracture decrease the symphysial plate failure? No, it is not. Adding an iliosacral screw to this metaphyseal plate fixation does not provide improved biomechanical outcome, mainly in fracture displaced land 5 centimeters APC2. Next. This is my last case. You see the size of the patient. The patient was 145 kilograms patient. She has an open book fracture with the anterior column on the left side. And we have done surgical repair. Next. And you see the osteosynthesis here. This is like it is exactly the previous video that I have shown, and showing that with the pin in the proximal part, we retract the pedicle under the pin, and to try to go very proximal and to do the osteosynthesis of the anterior column in the same time. Next. Then what you have to take home message, I try to simplify at maximum this type of fracture and give simple ideas. Challenging fracture, high risk of complication, mainly DVT, proximal DVT, EP, risk of AP. This patient that I've shown you, 145 kilograms, arrived to Tunis because she is not Tunisian, arrived to Tunis 1 week later, and she arrived with the DVT and EP. And she had treatment for 2 weeks, then we could do her surgery. It should be normally, when you receive your patient, it should be an emergency case. Try to fix this fracture as early as possible. The key point is to plan your surgery, and to well prepare your setup. You have a learning curve, but it shouldn't be very long if you are very familiar with the pelvic fracture. And thank you very much.
Thank you so much, Professor Sofiane, for being with us tonight. Thank you so much, sir. Wishing you all the best, and all our colleagues in Tunisia. Thank you so much, sir.
Thank you. Very happy to be with you.
Thank you so much, sir.
إن شاء الله نشوفكم في القاهرة.
إن شاء الله تشرفنا وتنورنا دكتور سفيان.
إن شاء الله.
Finally, at the end of this session, thank you so much, sir. I would like to thank all our eminent speakers and eminent panelists for being with us in this very important session.